thoracic.
Good evening, dear
We
colleagues.
need a lot of the blood volume, so you're killing a lot.
Welcome to this evening's symposium. My name is Ramalingam, and I work at the Winship Cancer Institute of Emory University in Atlanta, Georgia. We have a very exciting session planned for you. We're going to talk about stage 3 unresectable non-small cell lung cancer, a patient population for whom there have been some exciting new developments in terms of therapeutic options. I'm honored to be joined by two of my esteemed colleagues, Dr. Kristen Higgins, who serves as the Chief Clinical Officer and Professor of Radiation Oncology at City of Hope Cancer Center in Atlanta, and Dr. Jarushka Naidu, who is Professor of Medical Oncology, Consultant Medical Oncologist at the Beaumont Cancer Center in Dublin, Ireland. She also serves as an Adjunct Professor of Oncology at Johns Hopkins in Baltimore, Maryland. We want to start by thanking PeerView for providing this session and for AstraZeneca for supporting the educational grant that made this possible. There is a pre-event survey that you would have seen on your iPad, so we would request you to fill out those forms. And we also have some patient case questions built in through the event this evening, so we would appreciate your participation in that as well. We look forward to receiving your questions. You can do that through the iPads online during the presentation, and I'll field those questions to our faculty. You can also, of course, when we have time for panel discussion at the end of the didactic presentations, come up to the microphone and ask questions. This is a website you may want to take note of. You can download the slides from this meeting at your convenience. So today, at the end of the session, we would want to make sure that we are able to discuss clinical evidence on role of immunotherapy and targeted therapy for stage 3 non-small cell lung cancer. And you can see the other objectives. I'll just give a few second pause so you can read through the goals for this afternoon symposium. We want to start with a question just to get a sense for what are some of the challenging issues those of you who are taking care of patients with lung cancer face. This is something you can poll on your, respond to on your iPads, and you can choose as many of these. We want to know what are some of the most challenging areas in your practice when it comes to managing stage 3 patients. Number 1, is it differentiating between resectable and unresectable patients? Number 2, is it about determining the optimal radiation strategy? Number 3, is it implementing biomarker testing to guide your treatment decisions? And 4, is it in establishing the best multidisciplinary plan for individual patients, including how to incorporate immunotherapy and targeted therapies? So please answer. You can check as many as you think is appropriate for your situation. Okay, so that's an interesting spread of responses. We will cover all of these topics. So at the end of the session, hopefully you'll feel more confident being able to deal with these issues. The first talk is going to be by Dr. Kristen Higgins, who's going to talk about multidisciplinary patient evaluation and how chemoradiotherapy applies to patients with unresectable stage 3 disease.
Thank you, Dr. Ramalingam. So everybody in this room knows that stage 3 disease is very heterogeneous. We could have a single station N2 node, somebody that we think could be resectable, versus somebody with bilateral superclave disease, stage 3C. So these are the patients that I think are really the ones that need to be presented at our multidisciplinary tumor board. In my mind, every stage 3 patient should come to tumor board, because right now this is where there's really, I think, the biggest amount of controversy, and also probably the largest number of potential treatment options for our patients, many of which look very different. So these are patients that should be coming to tumor board and should be getting the multidisciplinary input. I think the most important decision in evaluating stage 3 patients in your tumor board starts with whether or not they are resectable. And that is certainly needs to be incorporated it with a thoracic surgeon in your tumor board. We don't have one on our panel today since we're focusing on unresectable disease, but just a note to make sure that when you're having these discussions with your MDC, that we're including our surgical colleagues. So again, when we're managing these patients, of course, we're doing our patient assessment. We're looking at things like performance status, other comorbidities, their pulmonary function, cardiac function, their goals of care, other potential social issues that could affect their ability to come back and forth for radiation each day, the amount of social and family support that they would have that can make their treatment successful. And those are all specific to individuals. And then we have tumor factors. Of course, we're trying to determine the optimal stage, which I think as a field we've gotten very good at because of the way we interact with our multidisciplinary colleagues, including our pulmonologists, radiologists. Of course, when we're looking at N2 disease, we're studying the images and trying to determine if those nodes are infiltrating into mediastinal structures. That's, I think, one of the key points when we're looking at resectability. And then also asking ourselves as radiation oncologists, are we able to deliver curative doses? I would say that for the vast majority of our unresectable stage 3 patients, we are able to use curative dose radiation with all of the available technologies that we have available. And then, of course, lastly, biomarker testing. We need to test for genetic alterations and, of course, PD-L1, and we'll be talking about that as we progress through this symposium. So again, differentiating between resectable and unresectable locally advanced disease, we have to rely on our surgeons for this. I think it's also really important that you use a CT scan with IV contrast to make sure that you can differentiate between your tissue planes, and that's really key to make these decisions. Of course, N1 versus N2 versus N3 disease, multi-station versus single-station disease, and then the infiltrative nature of those N2 nodes, I think, is also a key point. Certainly, we have seen that resectability status can change after concurrent chemoradiation, but I would argue that the decision about resectability should be made at the MDC before you start treatment so that the patient knows what treatment course they're going down and everybody, including all parts of the multidisciplinary team, are on the same page. Again, just making sure that we're all communicating with each other and that we're giving the same unified message to the patients. So what sort of patient evaluations are critical for stage 3 non-small cell lung cancer? Of course, the staging. CT scan with IV contrast, a PET CT, then we're looking to get pathologic confirmation of disease within the N2 nodes with typically an EBUS. A brain MRI with contrast is also critical. Physiologic evaluation with PFTs, cardiac evaluation if you have access to cardio-oncology services at your center. Exercise testing and frailty assessments are also something that can be done and typically are running through the surgeon if they're trying to determine if a patient is able to get surgery. And then, of course, that biomarker testing that is really critical, EGFR, ALK, PD-L1, and GS, that will typically happen as the patient is visiting with medical oncology. So let's talk about chemoradiation. The standard approach for concurrent chemoradiation is 60 gray with IMRT technique. There are multiple acceptable concurrent chemotherapy regimens. I think that weekly carbotaxol is the easiest to give. It's very patient-friendly. The toxicity profile, I think, is the most manageable. And I think many people have started to use this regimen most commonly after the results of RTOG 0617 that showed quite good results for the control arm. I want to touch a little bit about RTOG 0617 that established 60 gray as the standard dose and no benefit to dose escalation. Dose was escalated to 74 gray, 2 gray per fraction. We know that the standard of care arm, 60 gray, yields a 5-year overall survival of 32%. So that's the statistic that you can quote for best chemoradiation. What survival would you expect for your unresectable stage 3 patient? And I think it's important to have that in your hand when you're counseling patients, because remember, not all of our patients are candidates for other therapies after concurrent chemoradiation. So I think it's good to have that statistic when counseling patients. So last year at the World Lung Cancer Conference, Stephen Chung presented on the long-term results from RTOG 0617. Looking at toxicity, we know that IMRT technique reduces pneumonitis, and that's very important, especially now that we have consolidative immunotherapy that significantly improves survival. So we really want to use all the tools that we have available to us to reduce rates of symptomatic high-grade pneumonitis. And that is why I think that IMRT should be standard of care for all of these stage 3 unresectable patients. In Dr. Chen's analysis, they also found that looking at the dose to the heart is very important, and a particular metric, the volume of the heart receiving 40 gray or more, if it's less than 20%, then patients are surviving better. And you can see this Kaplan-Meier survival curve demonstrating superior survival if that V40 to the heart, the entire heart, is less than 20%. And this dosimetric constraint had not been something that we had used in the radiation oncology field prior to this analysis that was presented last year, and these results have been recently published in JAMA Oncology. So even though RTOG 0617 was a negative study, we continue to learn about best practices in radiation oncology. And then they also performed this multivariate analysis. You can see the heart V40 was a factor that was significant for overall survival, along with that radiation dose being 60 gray and not dose escalated to 74 gray. So we know that the dose to the heart matters, and that's really one of the take-home points from RTOG 0617. And I think that dose to the heart has also impacted future trials that we've designed as radiation oncologists, one of which is the role of proton beam radiation. You can see here that protons really can pull the dose away from the heart. Seen in these pictures, you can see we're able to really avoid all of that low dose to the heart, and that theoretically could improve outcomes. And it's being tested in RTOG 1308. This is a phase 3 randomized trial that compares photon versus proton chemoradiation for unresectable stage 2 through 3B non-small cell lung cancer. And this trial completed accrual in September 2023, 330 patients, and we expect that it should read out soon. Patients were allowed to get consolidation durvalumab. The study was amended to allow for these changes in standard of care. The primary endpoint for this study is a dual primary endpoint, one of overall survival or reduction in high-grade cardiac toxicity and high-grade lymphopenias. If either one of those endpoints is met, then the trial would be considered positive. So this is an unanswered question, and it may be that with this technology, we can even further improve upon the chemoradiation arm of treatment for unresectable stage 3 non-small cell lung cancer. However, we know that protons are very expensive, and they are not going to be widely available to everybody. So we have to explore other options to make chemoradiation better. And I want to bring up this phase 3 trial, which activated about a year ago within NRG Oncology. And so this trial is using SBRT to the primary tumor, but then continuing with chemoradiation to the involved mediastinal lymph nodes, followed by whatever maintenance immunotherapy, or it just got an amendment to potentially allow osimertinib as well. You can see the control arm is standard concurrent chemoradiation. The SBRT fractionation is dealer's choice. You can use a couple of different regimens. The chemotherapy starts with the conventionally fractionated radiation. The SBRT is given first. And the idea is that we could obtain better local control if we treat the primary tumor with SBRT, and we can also potentially reduce dose to the lungs. And you can see this axial image here shows that the isodose lines, especially those low-dose isodose lines, are contracted, and you're really able to spare the amount of lung that's in between that hilar lymph node and the lower lobe tumor. And so this, I think, is where this type of radiation technique could really come into handy. You're not having to treat the entire soup to lymph length of the lung when you're dealing with a lower lobe tumor and multi-station N2 disease in the mediastinum. So this is a great study. I urge people to open it at your institution, again, trying to improve upon that chemoradiation backbone for stage 3 unresectable disease. So what are the further unmet needs in unresectable disease? Certainly, we know that durvalumab has proved to improve overall survival for unresectable stage 3 disease. From the initial Pacific publication, it was unclear the role of durva for EGFR mutated non-small cell lung cancer, but certainly we have new data that Dr. Ramalingam will discuss as he presents during the symposium. So I want to just pose this question to the audience. The use of intensity modulated radiation for treatment of locally advanced non-small cell lung cancer is associated with which of the following? and now I will welcome Dr. Naidu up to the stage.
Kristen.
Thank you.
We have a quick question from the audience, Kristen. So thanks for that very clear, concise presentation. You talked about left side tumors, heart dose. If you had a patient with congestive heart failure and has a left-sided tumor, what sort of precautions would somebody need to take?
So I think the first thing is cardio-oncology evaluation. If you don't have cardio-oncology, just seeing a cardiologist to understand the symptomatic nature of the CHF and to make sure that it's optimally medically managed. Many of these patients have been walking around with CHF and aren't receiving any medications for their heart disease. So that would be number one. Number two, you could potentially look at using proton therapy if you had access to that technology to make sure that you're reducing the heart dose as much as possible. But also you can use other constraints and other substructures you can contour of the heart and put them into your treatment planning software as avoidance structures to get a better optimized plan that avoids the heart. And so if you have a patient that you're really worried about, that is one way I would suggest, is to try to add additional constraints beyond just a mean heart dose and the V40 like we talked about.
Thank you. All right, then we'll move on to the next presentation. Thank you.
Hi everybody, thanks for joining us today in this great symposium focused on stage 3 non-small cell lung cancer. My name is Naidu, and today I'll be talking about making the most of immunotherapy for unresectable disease. So we're going to start this section with a case. So this is a case of mine, a 72-year-old woman with a 9-centimeter lung mass that invades the mediastinum and N3 lymphadenopathy on PET-CT that represent biopsy-proven lung adenocarcinoma. So therefore, the overall stage using the updated classification is T4N3 stage 3C non-small cell lung cancer. The PD-L1 score is less than 1%. The patient has a good performance status, and molecular testing is negative for the presence of EGFR mutations. So based on this, and please feel free to score, what treatment would you recommend for this patient? Number 1, definitive chemoradiation, followed by maintenance durvalumab. Number 2, definitive chemoradiation alone. 3, thoracic radiation alone. 4, chemotherapy alone, or I'm not sure. And we'll revise the data and then come back to this question at the end. Okay, so this audience quite familiar with where we are, the majority voting for definitive chemoradiation followed by maintenance durva, so we'll review that and subsequent data from here and maybe some of the areas of controversy. Okay. So this is the data on which this is based, and now of course we have, this has mature data. This is 5-year overall survival and progression-free survival, and that's based on this phase 3 study, the Pacific trial. So just to recall, this was obviously conducted several years ago, and at that time, patients with unresectable stage 3 non-small cell lung cancer, importantly, who had completed definitive chemoradiation with a concurrent regimen and had a CT scan afterwards to show no progression. So this is an extremely high bar, and patients with a good performance status and archived tissue for PD-L1 testing were enrolled. So this included 713 patients who are randomized 2-to-1 to receiving durvalumab for a year on the 2-weekly dosing schedule versus placebo. And the co-primary endpoints were progression-free and overall survival. And as this audience is aware, we saw that this study met both the survival endpoints with 2 back-to-back New England Journal of Medicine publications. The first, in terms of progression-free survival, we saw an impressive progression-free survival benefit that appeared to last over several years. We see a clear separation of the curves, with at 60 months, around 33% of patients without progression, compared to just 19% of patients who did not receive durvalumab. And this translated into an overall survival benefit, so we saw something very similar, with again at 60 months, near 42%, 43% of patients alive at 5 years, compared to just 33% in those patients who did not receive durvalumab. Of course, the devil is in the detail, and here, looking at all the different subgroups, we saw that there were certain important subgroups that required further study. The first, of course, was patients with sensitizing EGFR mutations, which once again Dr. Ramalingam will go through in the subsequent section. But one semi-contentious area that we sometimes see some differences in regulatory approvals and for which there's still some question marks is in relation to the PD-L1 status. So we see here as part of the study, PD-L1 was certainly done using a cutoff of 25%, which was mandated for the study based on the antibody and the cutoff level at the time. But this, of course, was not the PD-L1 level that is now being used in clinical practice. So we see here that using a PD-L1 score of 1% in a post hoc analysis, which did not include all patients, we saw that PD-L1s of greater than 1% appeared to enrich for response. And based on this, this has underscored an approval in certain jurisdictions in the world based on PD-L1 score. However, in the US and in other areas, we know that durvalumab is approved regardless of PD-L1 status. So this is something that we will see and I think is important for us to discuss going forward. So coming back to our case, has this influenced any of your practice? And is there other questions that are relevant to day-to-day clinical practice? And I suppose the second is performance status of 1. How many patients truly with stage 3 non-small cell lung cancer or lung cancer in general have a good performance status? Certainly not every patient. And this gave way to the next very important study, PACIFIC-R, which was published in the JTO by Nicholas Gerard and colleagues. So this was a study utilizing real-world data of patients enrolled on a Pacific Expanded Access Program across Europe and several other areas in the world. So in this study, patients again had similar inclusion criteria to Pacific, stage 3 unresectable regardless of PD-L1 expression. PD-L1 was obtained in a subset of patients in which the data was supplied, and patients again were treated with 2 weekly durvalumab through the Expanded Access Program. In this case, the endpoints were investigator-assessed, progression-free, and overall survival. And what we see here is even though this is an expanded access program, that even enrolling in these types of initiatives where data needs to be collected still really allows only a sliver of life to be included in this analysis. So not every patient who might be a candidate in this instance was enrolled on this expanded access program. The goal was certainly to include patients who are more real world. And in terms of age, I think we saw this to some extent. So around 20% of patients over the age of 70 and around 10% of patients over the age of 75. Again, these studies are designed to maybe look at patients who are poorer performance status, but only 2% of patients enrolled on the study actually had an ECOG performance status of 2 or 3. So I think very little that we can really say about that subgroup of patients. Taking that all into account, we saw very similar benefits in terms of median progression-free survival in PACIFIC-R as we did in the bona fide phase 3 PACIFIC study. And we see here that at 2 years, 48% of patients were progression-free who enrolled on the expanded access program. This analysis did give us some important insights with respect to toxicity of treatment. So we see here that only 47% of patients enrolled on this completed all the planned treatment. So really the majority of patients don't complete 1 year of durvalumab. And why is that? So we see that the majority of cases were due to disease progression. So potentially their cancer needs something else. And around 17% of patients had an adverse event. And this is something I think needs further analysis. So what were the adverse events that were of interest in this population? So here we saw all adverse events leading to temporary disruption or permanent discontinuation, 11% and 16% respectively. And in most cases, this was related to pneumonitis or interstitial lung disease. And collectively, that accounted for 14–15% of all the discontinuations or interruptions, so a clinically important toxicity. Much less commonly, the other immune-related toxicities, such as diarrhea, colitis, hepatitis, or endocrinopathies. So really the synergy between radiation and immunotherapy here coming into play. This, of course, leads us into the most recent phase 3 clinical trial, exploring whether we can do more beyond PACIFIC. And this was presented at the European Lung Cancer Meeting earlier this year, PACIFIC-2. And this study was designed to answer the question, does concurrent immunotherapy with radiation improve outcomes for stage 3 unresectable lung cancer? Very similar population, stage 3 unresectable non-small cell lung cancer, but importantly, conducted several years after PACIFIC, and therefore we'll see subsequently enrolled a slightly different phenotype of patients. These patients were randomized 2-to-1, this time to durvalumab 4 weekly for a year compared to placebo. and the durvalumab could be continued until progression in patients who sustained some kind of response or stable disease at 16 weeks. Primary endpoint in this study was progression-free survival. Some important highlights here: the patient characteristics of those patients enrolled on PACIFIC-2 were very different to the patients enrolled on PACIFIC, as the standard of care for stage 3 lung cancer had evolved in that time. And what we see is that the majority of patients enrolled on PACIFIC-2 had squamous non-small cell lung cancers, had PD-L1 negative disease, had centrally occurring disease, T4 tumors that were larger and centrally occurring. So really a very different population that might be associated with a slightly worse outcome. And then of course mutation status not available in every single patient. So all these factors need to be taken into account, but regardless of this, the study showed no benefit in terms of both progression-free survival with a hazard ratio of 0.85, but a 95% confidence interval that crossed 1. And similarly, overall survival, a hazard ratio of 1.03, p-value of 0.08. So really telling us that there is no survival benefit when we add immunotherapy concurrently with the radiation. But of course, a different population to PACIFIC, patients starting immunotherapy at the get-go, not those patients who had completed chemoradiation and had not progressed. So completely different. So how did these patients do, and why do we think this outcome was the result of the study? So aside from differences in the population, we also saw some very important adverse events that really marked the study as different. So most patients who developed toxicity, this appeared to occur between 0 to 4 months from the start of treatment, approximately during the IO chemoradiation, so the combination part that included radiation. The most common of these were anemia, pneumonitis, as we've seen before, neutropenia, and nausea. The most common ones of the placebo arm were quite similar. However, we also saw some constipation and other toxicities. Taking a deep dive into the toxicities that actually were high grade or led to death, what we saw is, alarmingly, on the investigational arm, nearly 7% of patients had adverse events that led to death, the majority of which appeared to be infections, but we did see cardiac and other respiratory-related complications. Therefore, actually identifying that adding this treatment concurrently with chemoradiation may actually do patients harm. So future directions in this space, I think, will be very important to separate out the different flavors of stage 3 lung cancer. Now we're seeing a neoadjuvant approach coming forward for a subset of patients with stage 3 lung cancer. So identifying which patients in this group are going to benefit from a neoadjuvant approach, maybe with induction immunotherapy with chemotherapy as opposed to chemoradiation, will be a question, and is certainly one that is actively being debated. This is a study that is an example of a certain type of study that is trying to disentangle this. What defines borderline resectable lung cancer, and where is the line between a PACIFIC paradigm or a chemoradiation paradigm and a surgical paradigm? And I think this is an evolution we're going to see over the coming years. So in conclusion, the PACIFIC regimen is the current standard of care for patients with stage 3 unresectable non-small cell lung cancer, excluding those with sensitizing EGFR mutations and ALK alterations. PACIFIC-R was an expanded access program that aimed to assess the PACIFIC regimen in a real-world population and showed very similar outcomes to the original PACIFIC trial. PACIFIC-2 was a very recently reported phase 3 study aiming to understand whether adding immunotherapy to concurrent chemo and radiation was of benefit, and unfortunately, it did not demonstrate a benefit. Taking stage 3 in its entirety, the definition of unresectable is certainly evolving. Thank you.
Thank you, Jarushka. There are a number of questions. We can take most of them on the panel discussion, but I'll just pass one question on to you. We're going to hear about EGFR. You talked about PD-L1. Talk about your biomarker strategy for patients with locally advanced disease.
Sounds good. So right now, I think this biomarker strategy is evolving, and certain strategies are probably different ways to employ a biomarker strategy in different clinical settings. So for us right now, we do PD-L1 testing and next-generation sequencing on all patients with early-stage lung cancer. And this will allow us both genomic and immunologic biomarkers in which to select the appropriate treatment. I do think hotspot testing for individual mutations such as EGFR and ALK in this space is probably clinically appropriate with PD-L1, but as more mutations come on stream that we learn about that may impact treatment decision-making, a broader panel is likely to be appropriate.
Great. Another quick question. You talked about the PACIFIC-2 trial, some higher treatment-related deaths during concurrent chemo-RT. You're aware of the another trial where Pembro was given concurrently in a phase 2 setting. We didn't see that kind of a signal there. Do you see differences between agents in this space?
That's a very good question. So I think we know that there are differences in terms of PD-1 and PD-L1 with respect to toxicity. Anti-PD-L1 is certainly slightly better tolerated than anti-PD-1. However, in the metastatic setting, the consistent approvals have come first with the anti-PD-1 agents. I think right now I would say all of these agents are interchangeable, and I wouldn't see a biologic difference necessarily for them, but I think we probably need more data to truly be able to discern that.
Great, thank you very much. Okay. So my role is to talk about the role of EGFR inhibition in stage 3 non-small cell lung cancer. This is a recent advance in the treatment of this disease. I'll start with a case. This is more or less a similar patient situation that Dr. Naidu just showed us. A 72-year-old woman who has a large mass invading contralateral lymph nodes, consistent with adenocarcinoma, stage 3C disease. PD-L1 expression is less than 1%, ECOG performance status is good, and the molecular testing shows an EGFR L858R mutation. So for this patient, which of the 4 options shown here would you recommend? And I'll give a minute for you to read through and vote on this. The first option is chemo-RT followed by Durva. The second option is chemo-RT followed by OC. Third option is chemo-RT alone, and fourth is I'm not sure. Okay, that's wonderful. So let me then talk about the rationale for biomarker testing and what's the role of EGFR inhibition in this setting. As Dr. Naidu showed, the PACIFIC trial was reported in 2017, and Durva became approved in US and many parts of the world in early 2018. And since then, the question has remained that would this approach work for patients with EGFR mutation, which is using consolidation durvalumab. When you look at the PACIFIC trial, patients with EGFR mutation were included in this trial. And if you look at the lower part of the forest plots for overall survival and for PFS, patients with EGFR wild-type disease have clearly benefited from durvalumab, consolidation. However, for patients with EGFR mutated disease, we don't see the same level of benefit. In fact, it's questionable whether there is any benefit. Now, we've also come to see in stage 4 disease trials that patients with EGFR mutated disease do not benefit from single agent checkpoint inhibition or even with chemotherapy in combination with checkpoint inhibition. And therefore, the question is, what's the best strategy to treat these patients? There's also another report that's been published which looked at real-world experience, a cohort of about 37 patients with stage 3 EGFR mutated lung cancer. And 13 of them were treated with Durva, 24 did not receive Durva, and the median progression-free survival here was not comparable to what was seen in the Durva arm in the PACIFIC trial. There were a high proportion of patients who experienced grade 3 or higher immune-related adverse events, including 25% incidence of pneumonitis. And when you look at those PFS curves for EGFR mutated patients, there did not seem to be any difference for those who got Durva versus those who did not. This is not a randomized trial, just a cohort of patients who were treated. And some of those patients ended up getting TKI, and when you look at the curve on your farthest right, you can see that group of patients doing better than those who got durvalumab. So this question of what is the optimal way to consolidate patients completing chemo-RT if they had an EGFR mutation remained, and that was the basis for the LAURA trial, which we just published and presented recently. So this trial enrolled patients with EGFR mutated, locally advanced disease after they had completed chemo-RT. The trial design for practical purposes is very similar to what was done with Pacific. Up to 6 weeks from the time patients completed chemo-RT was allowed for enrollment to the trial. We allowed both concurrent and sequential chemo-RT, though I'll show you that nearly 90% of the patients received concurrent RT. Patients with exon 19 or exon 21 were enrolled in this trial. The randomization was 2-to-1 to osimertinib versus placebo. Osimertinib treatment was continued until progression or if the patient had to stop because of toxicity. This is different from the Durva strategy where Durva is given for 12 months. Here, osimertinib is continued indefinitely until progression. The control group received placebo, and at progression, they were provided crossover therapy with osimertinib. And I will show you data that 81% of the patients in the control group went on to receive osimertinib after disease progression, which is very good for a randomized trial for crossover post-study therapy. The primary endpoint was PFS as assessed by Central Independent Radiographic Review. So here are the results. 216 patients were enrolled in the trial. 143 patients were in the osimertinib group, and the remainder in the placebo group. The median PFS was substantially better for patients treated with osimertinib at 39.1 months compared to 5.6 months in the control group. The PFS hazard ratio was 0.16, and it was highly statistically significant. When you look at the 2-year PFS rate, it was 65% for patients treated with osimertinib, compared to 13% for patients treated with placebo. Now, when you just look at the placebo group and the median PFS of 5.5 months, this tells us that this group of patients, patients with EGFR mutation who present with locally advanced disease, most likely have micrometastatic disease to start with, and that's the reason why when you just follow them after chemo-RT without active therapy, nearly half of them progress within 6 months. And this provides the rationale why targeted therapy in this situation is highly beneficial. Now, the investigator assessment was also showing similar results when you look at the hazard ratio and the median. So both by independent radiographic review and by treating physician assessment, the benefit with osimertinib therapy in terms of PFS was clearly superior. Now I show you the forest plot that looks at benefit based on key baseline characteristics that includes age, race, smoking history, the specific type of EGFR mutation, and so forth. And practically in every group, the hazard ratio for PFS was almost less than 0.35 with the exception of one group. So all groups, key subgroups of patients benefited from osimertinib therapy in this study. What about response rate? We know that patients continue to respond even after chemo-RT. So when you look at the placebo group, 33% of the patients experienced partial response during the course of the trial, which represents ongoing benefit from prior chemo-RT. In the osimertinib group, the response rate was 57%, and the disease control rate was 90% with osimertinib. Median duration of response was substantially better, 6.5 months with placebo, compared to 37 months for patients treated with osimertinib. Now, obviously, in locally advanced disease, when patients progress, we pay particular attention to whether the progression happens within the area of treatment or at distant sites. And that's what is summarized in this slide. Overall, 68% of the patients treated in the placebo group had a site of new disease, compared to only 22% for patients treated with osimertinib. In specific, progression within the brain was substantially lower with osimertinib at 8% compared to 29% for patients in the placebo group. Progression within the lungs was also lower, 6% with osimertinib compared to 29% for patients in the control group. This shows us that using osimertinib after chemo-RT in EGFR mutated patients reduces both progression within the chest and in extrathoracic sites, in particular the intracranial metastasis. The survival results for this patient population are not mature. At this point, the maturity is only about 20%, and full survival analysis will be done after a 60% maturity has been achieved. Now, keep in mind that 81% of the patients in the control group crossed over and received osimertinib, and another 5% of patients received another third-generation drug that's used in China. So a very high proportion crossed over, and despite this crossover upon progression, the hazard ratio for overall survival at this point trends in favor of osimertinib at 0.81. However, that is not statistically significant at this point. We cannot claim superior survival based on these results. What I would say is there's a substantially clinically and statistically significant improvement in PFS with using osimertinib in the consolidation therapy setting. What about adverse events? Here are the overall results. Adverse events leading to treatment discontinuation were seen in about 13% of the patients treated with osimertinib compared to 5% in the placebo group. Any AEs leading to dose reduction was very uncommon, 8% in the osimertinib group. And grade 3 or higher adverse events of treatment-related etiology were seen in about 13% with osimertinib compared to 3%. What were the adverse events seen? This shows the overall results. Pneumonitis, specifically radiation pneumonitis, was the most common side effect in the control group at 38%. There was a slightly higher incidence of radiation pneumonitis with OC at 48%. I would point out that the duration of exposure is substantially higher for patients in this study for osimertinib, so they had a longer duration of time to report toxicities, and we think that contributed to that. And that's much more clear when you look at COVID-19 infections. It was 8% versus 20%. It doesn't mean osimertinib increases the risk of COVID. It's just that patients were on study for a lot longer, had more likely possibility of getting a COVID-19 infection. Now, the good news is vast majority of these toxicities were grade 1 or 2 in severity. When you specifically look at interstitial lung disease, it was 8% for patients treated in the osimertinib group. And of those, grade 5 was 1, and vast majority of them were grade 1 or 2. So overall, there were no surprising signals in terms of safety for patients treated with osimertinib in the LAURA trial. The conclusions of the LAURA study are shown here. It showed osimertinib showed a significant improvement in PFS in patients treated with osimertinib after chemo-RT with EGFR exon 19 or 21. Median PFS was substantially better, 39 versus 5.5 months. The overall survival results demonstrate a favorable trend, though full maturity has not been achieved. No surprises in safety results. And as a result of this, EGFR testing is now considered necessary for patients with stage 3 disease. Both NCCN and ASCO guidelines now recommend osimertinib for patients with unresectable disease after they have completed chemo-RT if they have EGFR mutation. Now, at this meeting, I would highlight another abstract from the LAURA study that provides additional information on safety profiles, specifically looking at lung toxicity, and that is in the oral session. Abstract 12.03 will be presented by Dr. Kato from Japan. We also have another abstract from LAURA study next week at the ESMO meeting, which will be presented by Professor Shun Lu, that looks at CNS benefit of osimertinib in the LAURA study. So keep your eyes out if you're attending these sessions. And I'll come back to our case as I conclude. For this patient who has a large mass, contralateral lymph nodes, EGFR mutation, I hope you would agree with me that osimertinib should be the standard treatment in this setting after they have recovered from the chemo-RT, as long as they have benefited from chemo-RT in terms of achieving either response or stable disease. So there are some additional questions in your iPad. We hope you will respond to those questions. And now we will move on to the panel discussion. And if any of you have questions, please feel free to walk up to the microphone if you want to ask a question. There are several questions. I'm going to start by asking our panel members. One question is, I think Dr. Naidu, you touched on this. What are potential reasons why concurrent chemo IO doesn't work for patients with stage 3 disease? Is there anything else biologically we should be thinking about besides toxicity?
I think this is a very good question for Kristen, as well as the radiation doctor. I think we don't have a very good answer really as to why concurrent doesn't work, but I think it's fair to say that this appears to be a signal that needs to be monitored, and that big picture, we need to understand when is the right time to give immunotherapy. And I suppose what we see from the neoadjuvant data is the earlier the better appears to be the take-home message. So how to interlink this with radiation to maximize the effect of both the radiation and immunotherapy, I think that's a biological rationale question, but certainly a signal to watch. I think for Pacific too, what's important is that these were already tricky patients to treat with various risk factors for having poor outcomes. Having said that, the control arm was chemoradiation. It wasn't the Pacific regimen. So really this was not of a benefit to these patients. Kristen, any idea of the radiation aspect?
Yeah, so we know that there are a high number of T4 tumors that are centrally located. Certainly when you're giving radiation to centrally located disease, there is a lot of blood volume that's getting radiation, and lymphocytes are very sensitive to even very low doses of radiation. So, you know, the hypothesis that I would put forth is that radiation is inherently immunosuppressive, and to get the maximum benefit of radiation and immunotherapy, you need to separate them in time and allow time for the immune system to recover after receipt of curative radiation.
Interesting, yeah.
Great, thank you. And this is a question for both of you. As you deal with a patient situation where a patient has completed chemotherapy and starts durva, do you see any patterns in when they develop immune-related adverse events, or is it just random?
Well, certainly, I think it's, what I've seen is a similar pattern to what we see in metastatic disease, that it does tend to happen earlier, depending on the toxicity. So for most immunotherapies, the toxicities will happen within the first 3 months of immunotherapy. And then after that, the sort of unusual ones, or those that might have a different type of natural history, might happen later. We certainly do sometimes see pneumonitis later in the disease course, but generally 3 months is when I monitor patients more closely. Kristen, do you have a different?
Yeah, I would absolutely agree with that. They tend to be early, so that period of time after concluding chemoradiation and those first few months of immunotherapy, I think, are really critical for educating patients to look for symptoms for adverse events.
Thank you. Dr. Naidu, again, you showed that bridge trial, which uses a neoadjuvant approach. So our audience member has a question. If after neoadjuvant patient is deemed unresectable and you go on to give chemo-RT, is there a role for adjuvant durvalumab in that setting?
So that is the purpose of the trial. I think these are some of the questions that we're struggling with in the clinical community. Is that upfront decision. So really when patients go into a neoadjuvant paradigm, they should be deemed resectable at the outset in order for this to be an appropriate choice. All the patients who enrolled on those studies were deemed resectable by the treating physician and the thoracic surgeon. I think this trial is asking a different question. It is asking the question that in patients in whom the role of surgery is debatable, which road would be better? So far, along a neoadjuvant paradigm, in my clinical experience so far, interested to hear what the other panelists' experiences have been, we're very rigorous about, is somebody a surgical candidate up front? Because we know the data for Pacific is so strong, it makes sense that they should be routed down a Pacific route if they are not deemed resectable. So far, there's been very few situations in a standard of care manner in which we have treated with neoadjuvant and then subsequently abandoned surgery for unresectable reasons. I think that that's a data-free zone. And right now, certainly in a European context where I practice, PD-L1 would factor into whether there would be a role in the durvalumab afterwards. And certainly a merging of the two is not currently standard of care. Kristen, anything you'd say there?
Yeah, I would say in those situations we have mostly given durvalumab after completion of concurrent chemoradiation, but you're right, it's a data-free zone, and you just want to make sure that these resectable patients are indeed resectable. The 20% of patients that aren't going to surgery in the neoadjuvant and perioperative trials, we don't really know what's happening to them. Some of them probably didn't need surgery because they progressed rapidly, but we really want to minimize non-standard of care treatment, which is what we're forced into for patients that can't get surgery.
Right.
Great. Kristen, this is a question for you. If a patient with an EGFR mutation has a large tumor, multiple level adenopathy, which cannot meet the dose constraints, could you do 1 to 2 months of EGFR TKI followed by chemotherapy?
Yeah, so I think that, that is an approach if you're unable to deliver a curative dose of radiation. There was actually a RTOG trial, RTOG 1306, that was designed way before its time, about 10 years ago, that was using that approach for patients with EGFR or ALK mutated non-small cell lung cancer, but it only accrued 10 patients, had to close early because that was before we had NGS and biomarker testing just wasn't being done and the patients were not being identified. So even though it's sort of a data-free zone, I think in that scenario, if you cannot treat them with curative radiation, then that is what I would do.
Okay, thank you. There's a question about what's the rationale for using placebo as the comparator in the LAURA study, and I guess I'll take this question. And this was an issue we discussed a lot when the trial was designed. It was very clear that for patients with EGFR mutated disease who had stage 4 disease, there was no clear benefit from immune checkpoint inhibition. We were also aware of the forest plot from Pacific trial that did not show benefit for patients with EGFR mutation with durva. The third practical consideration was if we did give durva as the control group, and if the patients have disease progression, we were concerned about overlapping toxicity if an EGFR TKI had to be introduced at that point. And in terms of patient safety, one would have had to delay treatment until you get out of a 2 to 3 month window after exposing patients to an immune checkpoint inhibition. So for all of those reasons, we felt that placebo is the appropriate control group for patients on the LAURA study. And I hope that answers the question. Are you aware of any, or I'll ask this question directly, the audience member wants, which is, are there any benefits to second generation TKIs post-chemotherapy? Jirushka, I'm not aware of any data. Are you with
No, I'm not aware of any data
afatinib
either.
or dacometinib in
No.
this? No. Another question about toxicity concerns. So again, Jirushka, I'll come to you with this question. If you're discussing osimertinib after chemo RT for a patient, what sort of toxicity concerns would you discuss with the patient?
Yeah, so I think exactly as we saw in the LAURA trial, all the traditional toxicities that we associate with osimertinib, again, interstitial lung disease, pneumonitis, Dr. Ramalingam showed it was really just an incremental increase in the incidence there. Other toxicities that we see from osimertinib, like skin rash, joint pain, abnormal liver function tests, routine cardiac monitoring that we need to do. These are usually the standard things that we would do in any patient starting osimertinib.
Great. Another question, what are timing considerations for consolidation osimertinib after chemo RT, and what assessment should be done before therapy initiation?
Yeah, I mean, I can take that. So normally we would start the osimertinib. Usually it's similar, several weeks after around 42 days, similar to the Pacific trial that we would allow patients to recover from chemoradiation before they start. There was in the Pacific trial, there was a question about whether starting the immunotherapy earlier was going to be better. I don't know if anything like that was done, Laura. Was it, Ramalingam?
The scan, you mean?
Yeah, the scan and the start date for the
we haven't done that analysis.
Yeah.
You know, that's something to follow. Okay. Back to durva. Do you use durva every 2 weeks or every 4 weeks after chemotherapy?
Well, I can say in the United States, we have widely adopted every 4 weeks since the pandemic.
That's exactly the same for me. I think at the time during COVID-19, there was equivalency data around the pharmacodynamics of 2-weekly versus 4-weekly durvalumab. They have certainly, as far as I'm aware, never been compared head-to-head. There is some anecdotal evidence that maybe 4-weekly treatment or less often treatment, similar to pembrolizumab Q6 weekly as opposed to 3-weekly, may be associated with slightly higher rates of toxicity. But we have seen our patients generally prefer the 4-weekly dosing regimen for practicality rather than 2 weeks. Has that been your experience?
Oh, yes, 100%.
Yeah.
So a practical question, Kristen, I'll ask both of you to chime in on. When you, as a radiation oncologist, see the patient on day one, just been diagnosed with locally advanced disease, multidisciplinary tumor board discussion has happened, and everybody agrees it's unresectable, what do you counsel the patient on their treatment course? Do you start talking to them about consolidation therapy? Do you talk to them about biomarker testing? Tell us a little bit more
Yeah,
about it.
so I try to give them a total overview of the treatment package so that they can plan their lives. So I start with the 6 weeks of chemoradiation, what toxicities to expect. You'll see me once a week. We'll manage them. We'll get you through it. You'll have a brief period of recovery, and then you'll start immunotherapy. And we'll make sure that any side effects that you have are managed before we start that part of the treatment. And then, the patient hears kind of the same message from medical oncology, and then they, I think, become very comfortable with the treatment paradigm, knowing it's going to be a longer course. I try not to make it too overwhelming. I say, let's focus on this first piece of it. We want to make sure that you get through this, because in order to start the immunotherapy, you have to successfully complete the chemoradiation. So, kind of not, I think it's sort of you don't want to overwhelm the patient too much. You want to give them sort of an idea of what's going to happen over the next few weeks, and then also the long-term picture. And as a radiation oncologist, as you see the patient once a week, you can kind of remind them of what to expect and how to build that into their plans.
Okay. Yours?
I do the exact same thing. I think that's just trial and error. I remember first telling patients, one thing at a time, just talking to them about the chemoradiation, and it didn't work out well. They need to know what to expect up front. Certainly when it's a commitment of 1 year of treatment afterwards, or in the case of if it's EGFR TKI, potentially lifelong treatment.
And at what point do you order the biomarker testing? And do you wait for the results before you start treatment?
Well, I think the good thing about unresectable disease is that we don't have to wait for the results before we start treatment.
Yeah.
So generally speaking, we would want to order biomarker testing right away, knowing that it takes several weeks to result, but we can go ahead and start treatment and not delay, which I think is the nice thing about the Pacific regimen.
Yeah, so we do the same thing. We do all the biomarker testing up front, and because chemoradiation is the first treatment, that buys us some time as to whether it's going to be immunotherapy or EGFR TKI afterwards. So usually I'll say there's going to be subsequent therapy, and while you're in your chemotherapy and radiation, when we get those results, I will go through what those are. And I think that buys us time. It's a little bit more pressured in the neoadjuvant setting.
Great. Well, are there any questions from the audience live? Well, I think that's all the time we have. I want to first of all thank our esteemed panel for their insightful discussions this evening. I want to thank all the members of the audience for participating and for your wonderful questions. I think the take-home messages from this session are: one, we're making progress in the treatment of locally advanced disease. Biomarker testing is now part of standard workup for a patient with locally advanced disease, and concurrent chemotherapy followed by OC is the new standard of care for patients with EGFR exon 19 or 21 mutated disease. With that, we will close and have a great evening. Thank you very much.